Hello, and thank you for being with us today to discuss advocating and justifying for the financial counselor position on behalf of the ACCC's education program entitled the Financial Information and Learning Network for Community-Based Cancer Programs. I'm happy to introduce Christin Lampley and Ernie Elemento. Christin Lampley is the supervisor of patient resources at Oncology Consultants, a 13-physician private practice with 7 locations across the greater Houston area. Welcome.
Thank you.
And Ernie Elemento is the administrative director at the Southwest Cancer Center at the University Medical Center Health System, a 400-plus bed county hospital serving West Texas and eastern New Mexico, based in Lubbock, Texas. Welcome.
Thank you.
So, Christin, let me start with you. Can you tell our audience what the current structure is at your practice with respect to financial counseling services?
Currently with our practice, we have 2 financial counselors. One is located in our Cancer Center location, which is in the Houston Medical Center. The other financial counselor, which is myself, serves what we call our West Side. We tend to serve as the last resort once patients or explain their financial obligations, or sometimes if we know up front, depending on the patient's situation, if it's something that we may need to go directly through a pharmaceutical company with. Typically, the way our office is set up, patients are brought to the practice. The doctors may decide on a cancer treatment. At that point, authorizations, pre-certs are completed. The financial responsibility is explained to the patient, and from that point on, we'll determine whether that patient is referred to the financial counseling department for additional assistance.
Our financial counselor is under a different department. The Southwest Cancer Center is a department of the hospital, and there's also a different department called the Financial Assistance Office, so that really it's their FTE, it's their person that they send to the cancer center whenever we need them. So it's not always the same person, but it's not an FTE that belongs to the cancer center. So it could be different folks.
What was your practice's impetus for bringing on financial counselors?
A couple of things. The first one is volume. With the current economy, there seems to be a little bit more self-pay folks, and UMC, University Medical Center, as the county hospital in the Lubbock area, we get most of the self-funded folks. Not just UMC as an organization in general, but the Southwest Cancer Center as well. So that was the big impetus there. We certainly have more folks that need the services of financial assistance. The second one was patient satisfaction. It's a service that is offered to patients, not just as an organization, but specific to the cancer center.
Okay, Christin, a question for you. You're in a practice, as opposed to Ernie, who is in a hospital setting. What was your practice's impetus for bringing on financial counselors?
Originally, we've created this 8 years ago. And of course, with the rising cost of oncology drugs and decreasing reimbursement, mainly to assist our medically uninsured and underinsured, at the same time, alleviating the financial burden with patients who are already dealing with the emotional distress of being told that they have cancer. It also enables us to decrease our patient AR, prevent loss of revenue, and also, most importantly, serving as an advocate to the patients and serving them in whichever area that is needed.
Okay, Christin, let's follow up on that. Was the financial counselor position a new position, or did current staff members or departments assume the responsibilities?
In the beginning, there were a few nurses with the practice that were handling some of the paperwork, but it wasn't as fast-paced or in high volume. So then the practice decided, well, let's actually develop this program or develop this department, not knowing in what direction it was going to go in. So typically in the beginning, it was giving me the groundwork. This is what we're looking for. This is how we would like it to go. We don't have a clue, so this is pretty much your area to investigate, build for the practice.
Ernie, a little about your setting. Can you explain how financial counselors provide financial assistance when coming from within other departments at your cancer center?
Sure, and originally, so this would be a few months ago, because this was a recent change. The financial assistance office is located centrally in the hospital, so that not just the cancer center, but various areas of the hospital whose patients need financial assistance, they have to make the journey down to the the central part of the hospital, actually in the basement, which was not always the friendliest place. They renovated it, they put nice colors and everything, and they made sure that the staff was friendly, but just the fact that you're going into the basement of the hospital, it wasn't the most conducive for the patient experience. What happened recently is they've assigned folks they've essentially decentralized the financial assistance office, so that folks now, or employees now, go to various parts of the hospital, like the cancer center, instead of us sending the patients over there. So yes and no. Is it a new position? No, because the position has existed before under the financial assistance office, but yes, in a sense that we now have a person at the cancer center serving the cancer patients, which is very critical to our patient satisfaction.
Christin, another question for you. Let's talk a little about the evolution of your center. How has your program developed and changed according to the needs of your practice over the past 8 years?
Well, now our department actually comprises of 4 individuals. Each of us are responsible for a certain aspect of the practice. 2 of us are strictly the financial navigators for the patients, while the other 2 actually work more so on the back end, working with payment arrangement statements and helping patients set up any type of financial obligations. So what we've done over the course of the years is it is centralized. However, what we've developed is a system of referring, which we utilize NextGen as our collection management tool. So by creating tasks to refer patients, and at the same time, what type of referrals are you seeing the patient with, we determine what course of action do we take with that patient. So for example, if you referred a Medicare-only patient to me, the first steps would be, okay, can you enroll into a Medicare supplement? If not only that, do you qualify for Medicaid? And as a last resort, do you qualify for any copay assistance foundations, or even can you transition into a Medicare HMO? So with all those steps into place over the course of the years to see what would best suit the patient, we've just developed an entire policy and procedure on how each patient will be handled based on the type of referral that comes to our office. And at the same time, in the event that the patient needs transportation services, we also have a nurse navigator now with our practice, so that can help with any prosthetics or transportation, home health, hospice care, even transitioning into another facility if we cannot help after we've exhausted all possibilities. And it pretty much comes full circle. So everyone in our practice, from the physicians, our pharmacists, the nurses, we even have our own research department, everyone works cohesively to make sure that the patient is taken care of from the moment they walk through the door until they walk out.
Christin, Ernie mentioned that his practice was decentralized. Let's talk a little about your structure. Your practice has 7 locations with 4 financial specialists. Are the financial specialists in one location, spread out, or is there travel involved?
No, again in Houston, since we're so large and we are spread out, one of the financial counselors, her office is located in our cancer center location, which is in Houston's Medical Center. My office is located, which we call the West Side, which serves all the offices on the outer loop within Houston. Then the other 2 ladies are actually in our business office, and they work, like I said, behind the scenes. So they're in there with the billers and collectors that work hand in hand on the back end.
And from our side too, that one of the biggest reasons why we decentralized was we wanted to skip that journey down into the financial assistance office. Precisely because also our pharmaceutical reimbursement program, since it's very chemo driven, it's obviously located at the cancer center. So there may be certain occasions where patients are or receive a more pleasant result with the pharmaceutical reimbursement component. But when they go to the financial assistance office, if it's not as pleasant, not the actual interaction, but the results that they're looking for may not be what they wanted, patients then will have the perception that, well, the cancer center can help me, but the financial assistance office, they're very difficult. So we're now segregated into different departments. So that's one of the reasons why we put them in the cancer center, so that patients will see them as part of the cancer center team.
Okay. And although we have 7 locations and I'm actually located in one, what we've done is educate our front office department in each of the other locations that I cannot physically attend, and just to kind of introduce the programs or just tell the patient, we're going to refer you to our financial counseling department, but here are the things that she's going to need when you do make that contact with them, and to kind of help expedite the process. And so patients can bring their information to that location, which is then scanned over to my office. All the folders for all the patients are kept with me.
How do practice and hospital settings strive to create a seamless interaction between the patient and the financial counselor?
We try our best to make sure that the patients are paper-free as much as possible, from the reimbursement with the pharma companies or even sometimes even the pharmaceutical company internal programs. We try to house everything. That way the patients don't have to worry about the paper trail.
And it's more of the patient experience, the overall experience. They come in with cancer. Their mind shouldn't be focused
about
on
paperwork.
what paperwork we need to fill out. They just need to focus on how they can get better.
How is the financial counselor position at your center funded?
For our situation, it's through the financial assistance office. So that was the nice thing about that, because I didn't have to go and justify an FTE. They already had a position in place. It was just a matter of convincing the financial assistants to house their folks at our department, which took a few meetings here and there. One of the issues that they had brought up was the volume. If they housed a person at the cancer center, would they be working 8 hours a day? And the answer is no, because not everybody that comes to our doors need to visit face-to-face with that person. So what we're doing with our system so that they won't waste a whole lot of time sitting there and they can go to other parts of the hospital that do need their services is we look at our schedule 2 days or a week in advance, and then we send them the time slots that we think patients might need to visit with them. And so they make it a point to be available at those specific time slots. Does it always generate a face-to-face interaction? Not all the time. Maybe patients called in or no-showed, and so you'd have a financial assistance person there without a patient to see, which is understandable. That's part of their job, I guess, to be available. But there are also times that they meet folks that were not predicted to visit with them. We didn't predict them to need their services, and they're not there. And so we call them, and then they come. So there's still a process that we're trying to put together to make the whole experience smooth and stress-free as possible.
We are actually employees of the practice, so we are actually on their payroll. We are there typically 8 hours a day. We average about 100 to 150 new patients a month that are referred to us for some type of assistance. And so from there, 8 hours a day, 5 days a week, we don't have time, or our focus is nowhere else but dealing with the patients and their services that are needed. So from applying to programs, monitoring the application processes, contacting the patients, keeping up with notifying everyone within the practice of the updates and what's going on, to actually having a financial counselor accounts receivables, because we have to keep up with the patient's claims as they pay to make sure that we're sending it in for reimbursement. So we're full-fledged 8 hours a day. There's no stopping.
Okay. In our situation, for example, if you have a patient who's self-pay, they come initially or for the first 2-3 times, and they visit with a financial assistance officer. For example, if they just don't qualify for anything out there, the hospital is graceful enough to set up a payment plan. You don't have to pay everything at once, but maybe whatever you can, so that their next 3rd and 4th and 5th visit, they may not need to have a face-to-face interaction with the financial assistance folks. So that's why they're not always there.
Talking about your workload, what type of return on investment do you expect from the financial counselors in your programs, since these services are not reimbursed by payers? Talk a little bit about how do you justify the return on investment.
Well, for myself and my practice, what I see that we have an increase in the intake of patients that come to our practice. When our marketing department or when we have new physicians that are going out to our referring physicians, this is one aspect of the company that we really market and advertise, that this is what we do. From what we hear, there's not a lot of private practices or oncology practices that actually serve in this capacity. It may have a little here and there, but not just all day, every day, and this is all you focus on, and it's a dedicated department within your practice. It builds the reputation of the practice within the community. As far as, of course, Houston is such a large oncology population, and so it kind of helps us to serve above in bringing this to the community and advertising it. So as far as return on investment, that's what I would say as far as the intake, the relationship, the rapport with the community, with the oncology community.
We have very similar metrics, most of which are run by the Financial Assistance Office, but they do track the number of self-pay patients that they've helped that now qualify for a program out there. They may track, or they do track, the number of self-pay patients that have agreed to a payment plan that they can continue to be self-pay. And I think more importantly, from our standpoint, from the cancer standpoint, is again the patient satisfaction that we track very closely. There's specific areas there that allow patients to make comments, so if it's a pleasant or non-pleasant interaction with the financial assistance folks, or if it's the outcome that they had hoped to, the result. So we track that to the patient satisfaction.
Ernie, let's talk a little about metrics. What type of metrics do you track related to financial counselor services, including number of patients assisted, amount of money recouped by drug replacement, and improved patient assistance satisfaction?
All of those. Yeah, all of those, from, again, patient satisfaction, and then the pharmaceutical reimbursement from a dollar standpoint, and then, again, those patients that are self-pay when they come in, and then they qualify for a certain program out there. Those are tracked. Those are the metrics that are measured. And the patients that don't qualify, but then they have agreed to a payment plan. So all of those are measured.
Christin, a little about your metrics. What type of metrics do you track related to financial counselor services?
Okay, so what we've done, kind of tying back to the question when you asked how has our department or this role in the practice, how has it improved or grown over the years and with the metrics. So to keep up with the metrics, what we've done over the course of the years and learning to be smart about it is in our system we've created from special payment transaction codes, adjustment transaction codes. We've even created what I call FINCO, which is my self-proclaimed acronym for a financial counselor. We've even set it up in a system as an indemnity type insurance. So for example, if a patient gets approved under one of the co-payment assistance foundations, FINCO is added to that patient's account as a secondary or tertiary insurance. And at that point, we can manually type in the name of that foundation after we add it. So at that point, once the payments start to come in, we can actually post that payment to that patient's account under the name of that foundation. So therefore, at each month end, then we can run a report pulling out that payment transaction code or adjustment code to benchmark track which foundations are paying the most. Then we can break it down by location to see, well, what part of town or what offices are you seeing the most funding or the most referrals from? At the same time, we break it down by physician, so even the physicians can see what type of return on investment that this position within the practice holds. What we also do is, in our system, we created a tasking process which is every time from our research department, nursing, collections, billing department, even the physicians themselves. If they have a patient that they want to refer to us, we can keep up with the tasking by what type of referral. So with that, we keep up with what type of payers are mostly being referred to us. We can then in turn use that metrics with our contracting department where they're going to the payers to try to negotiate a contract to say, hey, look, this is what we're doing for your patients who can still afford cancer care with your insurance, or the way that it's broken down, or the way that you reimburse. So we use that as a mechanism as well. And at the same time, going back to that, we can break it down by the drugs if it's a pharmacy related referral. So then we can see what drug is mostly being utilized, or what drug are we having the most reimbursement problems that patients cannot afford to receive. We also break down the drug replacement. So we, in our Links mobile system, each time a patient gets approved for a drug replacement through a pharma company, we can actually set that patient's name up in the system attached to that drug. So after drugs come in and we create what's called a restock activity report, that report is then turned into our payment posters, who then post the drug replacement to that patient's account. And since it's a transaction code that we created, we can then extract each month how many patients drug replacement came through and tie it back to the J code associated with the posting of that drug replacement in our system. And then that's also reported to the doctors to see what drugs that we utilize through the drug replacement program.
Let's take a minute to follow up. Would you both agree that the inclusion of the financial care counselors has added to physician satisfaction in the ability to meet and work with their patients?
Yes, I would say, although a lot of times doctors are not really engaged solely in the reimbursement aspect, I can personally say from our practice perspective, our doctors are involved from day one. We interact with them to let them know what's going on. It's appreciative. It also kind of helps educate them to know what programs are out there by keeping them in the loop and explaining to them what's going on, what are we doing, what options the patient has. And then it also helps to guide them in what direction they need to take with the patient.
Very similar with us. Physician and patient satisfaction have definitely, it dramatically impacts those factors. There may be certain approaches that physicians want to take with a certain patient, and then when they realize that funding could be an issue because this drug or this procedure might not be approved for certain diagnoses or whatever, then there is real-time feedback from the billing folks and financial assistance folks back to the patient, so they can then look at their approach maybe a little bit differently. Now, if they still feel that this approach is the one for this particular patient, then they can write letters that maybe would convince the payer sources to approve that type of approach. So yes, very much so. I think physicians are very happy to have this service at the Cancer Center, as well as patients.
Yes.